Hello and welcome. We are so excited, as always, to have Dr. Tracy Hug on the podcast today. We've been practicing that for the last 20 minutes.
It was perfect.
It is much better now than it was when I started, but I apologize. I'm going to try not to say your last name from now on. but Tracy has been. This is her second time on the podcast. She is in the news all the time. She was just on Freddie Sayre from UnHerd. And I apologize to Tracy for me and Michelle not being nearly as good looking as that Nordic Viking guy. I mean, it must be hard to answer his questions. He's so darn good looking. Me and Michelle, it's like, oh, you're like, things are rolling up.
Speak for yourself.
Anyway, Dr. Hug, she's here not just because she is so pleasant. She is an MD PhD. Her field of study is epidemiologist. She's a bona fide epidemiologist. That's what she does on her when she's not busy being a physical medicine rehab doctor in a private practice in California. She's a consultant epidemiologist. She's actually published a number of peer-reviewed papers, which have all been proven to be right in the long run. And she's has one of the most gentle demeanors, despite getting an incredible amount of flack because every now and then her data goes against the blessed divine consensus. So thank you so much for coming on.
Oh, thanks. That was such a nice introduction. I've been really looking forward to this all week since I knew we were doing it, because people don't know that we're actually friends in real life now. So
I know.
I dressed up with my very cool band t-shirt.
Oh, excellent.
I wanted to show that this was more casual. We all know each other. So.
Excellent. Well, no, I mean, because you're so accomplished, you can show up in a t-shirt. I'm a random private cardiologist. I need to actually.
I just thought it was the cool thing to do, but you look good in a suit, so maybe I was wrong.
All right, so you are here because there is a paper that is burning up the world of Twitter. A study that was published by the Florida Department of Epidemiology. There was a bulletin that went out, I think it was last Friday in the evening, 6 p.m., saying, there's a study that we're releasing. The study suggests there's a higher rate of cardiac death after mRNA vaccinations in young men, 18 to 34, something like that. And it seemed like the bulletin, the bulletin explicitly said that because of, in part because of this, we are no longer recommending mRNA vaccination to young men. That is the Florida, and that was according to the Florida Surgeon General. The Florida Surgeon General, who is also a friend of yours, we must say, Dr. Joseph Ladapo, who himself is an MD PhD, who was appointed by Governor DeSantis at some point last year. Anyway, so he tweeted this out, and immediately there was consternation. Twitter took down his tweet, violation of terms of service, and then it was like, wait a sec, that's maybe not the best idea to pick a fight with the governor of Florida. And so they were like, oh, I guess the governor and the Surgeon General, who's an MD PhD from Harvard, maybe they're allowed to have an opinion
right.
about data. They reinstated it, but that did not stop the Puritans. The Puritans for the last 6 days have been waging an information war. And now when I Google Ladapo Florida study in preparation for this podcast, the first 7 hits are expert slam study, scientific consensus is, it says this study goes against, whatever, experts say this goes against scientific consensus, blah, blah. Dan Diamond, who is you may not know, Dan Diamond writes for the Washington Post. He is particularly good at getting Republican scalps. He's the one that got Tom Price from HHS fired from under Trump. And anyway, he has a long storied history of going after Republicans, and he wrote this long article and talking about how even Ladapo's mentor said this study is does not up to snuff, and this is well outside of the norms of what we should be doing. I'm sorry I'm taking so long, but it's just incredible to me this is happening. So I want to document it. The editor of Science Today, Holden Thorpe, the editor-in-chief of Science, he wrote an editorial today. He was aghast that the University of, among other things, that the University of Florida, where Dr. Ladapo has a medical faculty appointment, that they are not doing something about this incredible disinformation that is being released, and he wants these things to be policed. So anyway, what is so incredibly controversial about the study?
Yeah, I mean, I think the reason there's been so much outcry is it goes sort of against the majority view of sort of academics and who are maybe on social media and on Twitter. And, I think part of it is that they're okay. So we should probably, go over a little bit what it found, that it found this 84% increase in risk of myocardial death within the first 28 days after mRNA vaccination in males 18 to 39, compared to weeks 5 to 25, or starting week 4 to 25 after the vaccine. And so I think that it came with a result that people kind of viewed as maybe potentially being dangerous to COVID vaccine uptake. And I do think that, that's kind of why the outcry came. And it was very interesting because I was kind of watching it unfold from the beginning, and sort of the initial wave of people responding were like, "Oh, you're a hero. Thank you so much for speaking the truth, Dr. Ladapo." And it's like, and then I thought, oh gosh, I didn't think like people had actually, read the study, and I could immediately tell people didn't understand the study design. But then there was the second wave of people who were really just sort of attacking the result of the study. And it seemed like many of them hadn't actually read the study or understood how the study was done either. And so it was like a very visceral response from two sides of the political spectrum. One of the sides of the political spectrum, happens to sort of have more power in academia and med Twitter. And so, I do feel like we can definitely discuss the limitations of the study and how small it was, but it was a little bit of a double standard compared to, maybe the outcry that we should have seen about all of the terrible mask studies that were done that resulted in children all across the world, or in many countries, having to wear masks for years in school with just terrible evidence and confounding factors and variables. And then, also the really bad data that we've had on vaccine safety and efficacy. And so it was like this really sort of painful double standard of like, this is unacceptable misinformation, but all this other stuff that was, in many ways, maybe even worse, is why was that fine? Like that doesn't make any sense.
Right. No, absolutely. But here, tell me about it's absolutely the thing that should strike anyone that's even mildly objective is that, my God, every 2 days there's a long COVID. Now there's medium COVID. It's just insanity. In terms of
medium COVID's been actually, I think, was going on for a little while. And I thought, do we really need to call it anything? I don't know.
Yeah, anyway. Right. Just the sheer quality of studies that are put out. Just today there was the Washington Post that just put out this thing slamming this Florida study as, oh my God, this is the worst thing since whatever, and this is clearly politically driven, blah blah blah. The science is horrendous, and they literally put out a powerful new study on showing that hundreds of thousands of people on 100,000 trial study that suggests that long COVID is going to be a huge problem, right? And you read you start to read the article, and like the first line of the methods is that 100,000 of 600,000 or something like that, people responded to a survey. So the whole thing is based on a 16% response on a survey, right? And
that's not acceptable. Obviously,
how is that?
Epidemiologists would know that, right?
That's right.
Anyone with common sense.
Yeah, and there are no editors of the journal. There's no science editors that are writing editorials about misinformation and contacting the school. The people who publish that.
Yeah.
their medical faculty and stuff. But here, we do want to get into the details of the study itself. So what the study, I mean, basically, I mean, all vaccine studies, or all studies that attempt to do this, right, to look at adverse events after after exposure to X, we'll say. They all have certain upsides and downsides, right? Generally speaking, the huge problem with all these studies, right? I mean, the major problem in terms of trying to ascribe cause, the major problem is trying to define a baseline level of risk, right? That is almost always what you really struggle with, right? Because how do you know after you got a shot of whatever it is, it doesn't have to be a vaccine. If you got a shot of something, right, and then you have a heart attack 2 days later, I mean, heart attacks happen. I mean, if you didn't get the shot, you may have had a heart attack. How do we know that this heart attack was related to this shot? And that's the way we try to figure that out is by trying to define as clean of a baseline level of risk as you can, and then comparing what the events are after therapy X, correct?
Yeah.
So in this particular case, they use something called a self-controlled case series. Now, why would they do that, Tracy, in this particular case?
Right. No. So basically, I mean, we can kind of go over the different types of ways that you can study the vaccine safety, but I mean, the best way to do it, obviously, is to do a large randomized study.
Right.
And so, we have the initial randomized data from Pfizer and Moderna. And I think we should just remember that the studies that we have in children, especially, were too small to really state anything about rare, serious safety signals. Not that this study was in children, but you have a randomized study, and then you can control for differences. It should self-control for differences in health between vaccinated and unvaccinated. So that's been an issue, because we also don't have any randomized studies for booster efficacy and safety. And so we've kind of been relying on large observational studies to tell us, what's the efficacy, what's the effectiveness in that case of an observational study. That's what you're looking at, and what's the safety. And so an issue that has been coming up is when you're looking at observational data, especially in adults who have chronic illnesses that predispose them to having problems like cardiovascular disease or other adverse events, are more likely to be vaccinated in many cases. And that's been very hard to control for. And so this self-controlled case series actually takes care of that, because you are comparing like the same group to the same group. So you don't have any changes in health unless there just happens to be a time component that may affect the early risk rather than the later risk. So like, for example, in this study, the self-controlled case series. So this is an established way of looking at vaccine safety and safety of any intervention that you want to look at. And then you see, when does this anticipated adverse event occur? Like, what's the proximity to the treatment? And so in this case, we're looking, what's the proximity to the vaccine? And so they actually adjusted for the fact that there was a change in season during the whole 25-week period. I don't know if you noticed that, but if you calculate the relative incidence in this study, it's actually been slightly adjusted. And so the relative incidence should have been 2.01 rather than 1.84 had they not adjusted it. So it was actually, they actually adjusted it down from the rate, the incidence of the severe event that they found in the 18 to 39-year-old. So that was just something I figured out when I was looking at the data. But anyway, so this is, I think it was a very smart way of looking at vaccine safety.
And we should mention that this is not complete. I mean, using this method is not completely out of
no.
because Oh, the UK, right? It's called the ONS.
There was the UK study, and then there was the JAMA Network Open study. I'm just actually going to try to bring that up right now. That was from the Nordic countries, where they also use the self-controlled case series, and I'm just trying to bring that up right now.
Oh, they did.
Yeah,
so that was this Anders Svud guy. So they also did SCCS?
Yeah. So exactly. So if you
the
look,
JAMA Cardio paper.
No. So this is actually the analysis of thromboembolic and thrombocytopenic events, and they look at the different vaccines. And let's see. So self-controlled case series was the design of that study as well, that was published in JAMA Network Open. And so they were mostly most of their population was older, so older than they were born earlier than 1971. So they actually did find some pretty significant adverse events in that study too. So I think, a lot of people don't realize that. And if they found intracranial hemorrhage to be.
So two other large reputed groups. The Denmark study, the Danish investigators that are well known. The ONS, the UK.
Yeah, exactly.
They use SCCS for exactly the reason that you're saying, because the group serves as its own internal control, meaning they're comparing right. But of course, there are some differences, and of course there are disadvantages, right? I mean, obviously, just can you try to explain in a layperson's what exactly the problem is? I mean, there's limitations to every one of these things. I mean, there's a problem in the randomized control trials. The problem with randomized control trials, as you just said, and I'll repeat, is that the randomized control trials we have, there aren't that many 16 to 17-year-olds, right? And so if you have an event, so the good news is that, okay, it's rare in the sense that it doesn't happen in 1 in 5 or 1 in 10 or whatever number of people there were there. But if you're going to roll this out to 25 million 16 to 17-year-olds in the US, right? Mm-hmm. Well, that's a limitation of the RCT, because unless you run an RCT for a bajillion years, it's going to be hard to enroll enough people to find some of these rare events. So that's one of the issues with the RCT. But of course, with the self-control case series, there are, the upside is what you said, but there are downsides. So what is the downside of using this?
Right. So they were not able to compare to unvaccinated people. So that's, one thing, so that they were not able to say what the absolute risk was, vaccinated versus unvaccinated. And then, something to consider as well is like, what is going on when people actually get vaccinated. So just so everyone remembers, everyone in this study was vaccinated, everyone died. Okay. So is a person more likely to be healthy when they're vaccinated at the moment they're vaccinated, or more likely to be sick? So that's a confounding factor. And so maybe, people are more likely to be healthy when they're vaccinated, in which case this is a surprising finding to find that they died, closer to the vaccine than later. And if that makes any sense. Okay. So then, so then there's the issue of just what is the overall rate? Like, they excluded people who had COVID at the time. And so we don't, and then there's the issue of sort of, attributing it, like the cardiac death, like, did we miss some of the cardiovascular death? Like, was some of it coded as incorrectly in terms of, the codes, the ICD-10 codes that they use? So, what is the actual rate of truly the rate of cardiovascular death after the vaccine? So we don't know, we have some uncertainty around that.
Tracy, can we back?
And it's a small study.
Right. Can we backtrack just a little bit? Yeah. So there are these databases. Again, I think a lot of people don't know, there are these databases that continually monitor things. So this is based on linking databases of vaccination and databases of certain reportable events and that sort of thing. Can you go into this a little bit? Because I don't know what how much people know, and then within those databases, then you examine the rates before the vaccine and then after the vaccine, or over certain
right. Yeah. So that's a good point. So that's we with this method, we don't know what the rate was before the vaccine. So that's another downside of using this method. So we basically they based the study on death certificates, and then what they did was they is if I'm understanding the study correctly, I need to repeat that I wasn't one of the study authors, but and then they got information from their the Merlin database in terms of who had COVID and who hadn't, and that information was also on the death. They also, some of them had that information.
So how do they do that? How do they identify that this death certificate? How do they identify that this is the same individual in the Merlin database? I mean, is it simple enough that you just date of birth and whatnot? And
I think it's date of birth, and I would have to check exactly how they verified it, but that's a good question. So I believe that.
But I mean, I suspect that's a common. There's a common way of doing it.
Or state IDs were involved. So
okay, but that's a common way of doing it in epidemiology, right? When you do these kind of database studies, you cross-link databases. Then there's some way of trying to determine that that's the same individual, on the death certificate. Then you can see if that person had COVID or had not had COVID, or had been vaccinated or not been vaccinated. Because that obviously is not going to be on the death certificate. So
exactly. So that was, again, they were using their Merlin database in Florida to determine whether or not they had been vaccinated. So so that, exactly. Okay. So it does involve cross-linking databases, as you say.
Okay. And so from cross-linking databases, they have these people who have died of cardiovascular disease and whatnot, and they can see how clarify for me, how is this a group is their own self, it's a self-controlled case series. So what's
so basically so you have this group of people who have all you know that they have all been vaccinated, and you know that they have all died within 25 weeks of their last dose of their vaccine. And so booster doses were excluded. And then essentially what you're looking at is, are they disproportionately more likely to die in those first 28 days than what they call the baseline period, which is the period from the start of 4 weeks to 25 weeks. And and a lot of people's critique of this method is that's arbitrary. So I will say that the JAMA Network Open article also used the 28 days. And I know that the Florida study, they went out to 25 weeks because that was the end of when they felt that they were sure that they had gotten all of the death certificates. And so I think it's important to say that it seems like, at least for the other study groups, they didn't detect the same signal. So it seems, that seems to be a sign that they did go out far enough with the 25 weeks, or they didn't end it too late. Like it seems unlikely that they were missing death certificates, but that's that's a limitation of the study. But otherwise it's unclear why exactly they chose the 25 weeks. And certainly, one could say, well, maybe people are at risk of dying, 4 months or 3 months after the vaccine compared to the next 4 months. That would be another way to look at it. And so they may have actually missed some risk that way. Or if the risk is really most severe in the first week or first 2 weeks, maybe they could have done it, the first 14 days after vaccination and then compared it to all the other weeks. And so, I would be interested to see just like, if they could do all those different comparisons, you could actually determine where is the strongest signal, if the signal is even real. Like, in terms of when the highest risk is. And it brings up this other like really important point, which is that the signal that they detected was based on such a small number of deaths that if you just even, misattributed one or two of those, or then the signal would disappear. So it was actually a very small number, total in the study. And so that doesn't necessarily give it enough power either to detect signals that may have been there. And so, for example, maybe the signal is also there in women of the same age. Maybe it's also there in older men, but they just didn't have enough power to detect it.
Right. So just to be clear, what they discovered is that by linking those databases, they discovered that in the first 28 days after receiving the vaccines, in men in a certain age group, the rate of death was higher than in weeks, from 28 days until 25 weeks.
Right.
Whereas in women and other age groups or whatever other things that they've looked at, that wasn't the case. The rate of death seemed to be similar.
But the total number of deaths among women,
right, it's a handful in each in each case, because these are young healthy people presumably, and therefore one extra death here or that may have tilted the balance one way or another. Okay, all right.
So the other thing is that one thing that's how you define the baseline period is important, right? Because the UK had a slightly different approach where the UK only used 6 weeks post-vaccine as exposure and weeks 7 to 12 as control. So Florida, just to review, used 4 weeks post-vaccine exposure and weeks 5 to 22 as control.
Right.
And if you do that, then it's possible that it's possible to fiddle with, it's possible that you end up double counting. Yes. In that latter period of time, because it's so much longer. But it gets to this point that the numbers are so small that these are very, very fragile results.
Yes,
so
absolutely.
So the study, and I think I tweeted this at some point on Saturday or Sunday or something like that, saying that on its own, it would seem like be a ridiculous thing to use just this study to say that, hey, we should not be doing this to young men. But of course, this is in context of a lot more stuff and multiple data sets that have suggested higher rates of myocarditis. And so if you have if you have some small signal that suggests maybe there's higher mortality, and maybe it's being driven by this, then it's not something that we should dismiss out of hand. It's certainly not something that we should not allow to be published or something like that. So
right, exactly. I think you stated it perfectly, because you really have to look at this study as just a very small study with, like you said, very weak results. And really, I would understand if anyone just dismissed it if it were, not in the context of all the other risks that we see in this age group. So it was really, just striking from the sense of, this is really the age group that has been found in many, many studies over and over again to be the highest risk of myocarditis. So the fact that they also showed up in this very small study that was very, actually underpowered, it makes you, wonder, is it real? I don't know. If it's obviously it's very small. It's a very small number we're talking about. Right. Like we're all talking about, all the excess mortality in this age group in Florida, right? And I don't know if you've been following that discussion, but obviously this number of deaths that we're talking about, this tiny number, like this would contribute like a tiny little sliver to that amount. So
that's the other thing, right? I mean, it's actually, it doesn't show, for instance, 16 to 17-year-olds are the ones that have the highest risk in multiple different data sets, or slightly younger than this. And so there's a bunch of stuff that is, doesn't completely jive with what we do know, which just suggests that it's a kind of a, small study and it's important.
Yeah, well, they didn't look at people at less than 18.
Okay. All right.
So
well,
that would explain that.
So can you explain a little bit more why they chose to exclude the people with COVID?
Yeah, because I think that they didn't want it to be a result of that if they had COVID at the start of the period or something like that, that somehow it would affect the results. But I think it's a fair question why they chose to exclude people, because really they could have been at risk for COVID all along. But the thing is, if they're just being vaccinated, I mean, there is a sort of an increased risk of having COVID before the vaccine actually takes effect. So I wonder if that's what they had in mind, that they would be more likely to get COVID than at the beginning of the study, and it could potentially affect the results.
But then could it have excluded people who have had recent COVID? I mean, I presumably they would have had that information and excluded those patients with COVID.
Well, I think they did exclude the patients with COVID.
With COVID within a month of receiving the vaccine.
Yeah, I mean, I would, that would be definitely a question for the research group, which points to the fact that it would be nice to know who exactly the authors are, because I think many people have questions like that about, why was it easier for them to get data on patients that currently had COVID for some reason than those that had just had it. And I suspect that's why they designed it the way they did. I think a lot of people have been suggesting that the way the study was done was sort of like nefarious or cherry picking. And I guess maybe one thing that I can add to that conversation from having actually worked with this epi team is that's like the exact opposite of how they strike me. And so, I suspect that they made the decisions that they did sort of based on what they could do with the data and the limitations that they had within the Florida databases. So, yeah.
So Tracy, what is the kind of the claim and from the bulletin was that, look, there's maybe increased mortality that is related to in this age group in young men. And again, Florida's not alone in coming to these recommendations. For a long time, there have been multiple other countries that have, specifically advised against, specifically Moderna, which is thought to have, because it's 3 times the dose as the Pfizer mRNA vaccine seems to have a higher rate of myocarditis. So Florida is certainly not alone and off on some strange Mars type trajectory. They're very much in keeping with those countries that exist across the Atlantic in this continent called Europe. That multiple of those folks have also recommended against the vaccine for young men. But in your estimation, what would be the strongest evidence that we have, or the strongest signals, I should say, that make you concerned about overall higher mortality, which is a big claim, which is why all of us are so cautious trying to make it. I know, you've mentioned a couple of times and alluded to it, and you've tweeted about the higher all-cause mortality seen in 25 to 44-year-olds. This is based on the CDC Florida data, shows an increase in all-cause mortality in 25 to 44-year-olds over the summer and early fall of 2021. So the question is, is that something that is concerning, and what is driving that, correct?
Right. So it's still an open-ended question about what exactly in Florida, and particularly in the South, was driving that big spike, because there was the Delta wave, but looking at the number of deaths, from the Delta wave, it doesn't fully explain the excess that was seen there. But you have to look at this sort of in context of other states and other countries as well. And so, like, we did not see that spike in excess mortality, like, for example, in New York. And so, right. I think that's very important to look at examples like that. And then also in Europe, there's been a big sort of a spike in excess mortality that actually really that's been continuous, but actually, if you look at Sweden, really hasn't been seen, maybe only very slightly. And so it's important to remember that Sweden has a very high vaccination rate, But they really haven't seen that excess mortality. They have like 75% vaccination rate, and but they didn't have lockdowns. And that's why I always like sort of focus on Sweden, because I'm like, well, we didn't see like the changes in physical activity there. We didn't see the changes in probably like diabetes and other cardiovascular disease, all that stuff. So, you know, I don't know. I think that, you know, most of the excess mortality is due to changes from the lockdown, like delayed medical care and just, you know, mental health problems and then sedentary lifestyle and things like that. But there may be a signal. The problem is if there's a signal from the vaccines, it's small, right? It's going to be small. And so how do we pick that up? And that's been the challenge. And so you really have to do that in correlation. Like we've kind of talked about before, or not on this podcast, but like on Twitter, like the Israeli study was it was a good way of doing it, because they looked at you know, exactly when the wave of vaccination was in young people. And then they actually looked at EMS calls for what was it? It was like cardiovascular
cardiac arrest, right?
Cardiac arrest. Yeah,
exactly. Calls, right.
And so that was it. So like all of us are kind of like thinking, okay, well, is that going to be replicated other places? I've actually been working with RETSF on trying to like look at other places where we can try to do that study to see if it shows up. But that's one way of doing it, is correlating it with the vaccine, like when especially the second doses of vaccine were given, and then sort of look at when there's a wave of death. So
because one of the issues, for instance, you know, that great podcast you did just yesterday or the day before with Freddie Sayers from Unheard. They had a Swedish investigator who he's an epidemiologist who talked about the JAMA large 23 million patient observational study he did, and they published in JAMA Cardiology. And that, you know, he was pretty confident saying that, hey, look, we did the study. We do show higher rates of myocarditis with the second dose. There's mostly Pfizer over there. We do see higher rates of myocarditis with the second dose, but he was very clear to say, look, we're not seeing much death. And I think what he doesn't realize, and this is what we talked about briefly right before we started recording, was that you know, if you simply are looking at myocarditis, right, myocarditis that gets coded in an EHR or in wherever, and then you look at death after that, what you may be missing is a signal of death that's outside of that, right? So people that are too sick to make it to the hospital. So this survivorship bias of, you know, the World War II planes that were, you know, that landed and they saw where all the bullet holes were, and then somebody had the bright idea to say, okay, oh, those are where the bullet holes are. That's where we need to fortify and put the armor on there. And of course, what that misses is that, well, the places where the bullet holes are not, those planes aren't returning. And so, and, you know, unfortunately, VAERS, you know, that nice study you had in the VAERS, that VAERS, that looked at the VAERS database, you know, there are some concerning cases reported of deaths before anyone even made it to the hospital, right? Now we don't know, and we can't say without autopsies what exactly was going on. Some of those autopsies did show myocarditis, and again, it's the whole problem of like, maybe this was a myocarditis case that was not linked to the vaccine, right? But hey, it clusters after the vaccine, and that's so hard to do and so hard to figure out. But all that being said, the issue with what the Danish epidemiologist said on Unheard, that immediately came to mind when he was like, well, look, we just don't see deaths. We don't see deaths after the myocarditis diagnosis. It's like, well, okay, sure, great. But that just may be that the myocarditis cases that make it to the hospital are the mild ones that end up, you know, doing okay. And when I say myocarditis is mild, like, of course, I've written pages and pages of the fact that having chest pain, spilling troponins, being in the hospital for multiple days, not being able to exercise for 6 months, that's mild myocarditis, all right?
No, but isn't that a little implausible, Anish? Isn't it a little implausible?
Why is it implausible?
That all the deaths would be in people who haven't made it to the hospital, and the ones who make it to the hospital.
I'm saying it's obviously rare, because obviously as a busy cardiologist in a large metro area, I mean, I'm not seeing people dying, kids certainly dying left and right. We would know them if it was more frequent. But the point is that there may be some rare signal that you're missing, and the only way to catch that in terms of what that signal is, because I mean the problem is it's this ethical issue, right? It's not that, it's that literally you have a state, almost compulsory in some level, or has been, and maybe that's changing and that's good. But you have a state mandating this, kind of forcing it, kind of lots of people pushing it. Michelle, it doesn't take like that many deaths, to happen for you to put a complete stop to something like this. But the hard part is, it seems like it's relatively rare. But the only way to catch that relatively rare thing is going to be some type of study that looks at all death after vaccines, not a study that looks at myocarditis diagnoses that come to the hospital and then end up dying. It's entirely possible that you have some cases that are out there that people are getting so sick and not making the hospital. By the way, the New England Journal paper from Mebarak in Israel from April of, or whatever, June of 2021, whenever in 2021 it was finally published. That has, right, Tracy, one case of very severe myocarditis,
and where he died. Yeah, exactly. So there's definitely been a handful of cases in the peer-reviewed literature of myocarditis where people have, where young males have died, and so we know that it's possible. And then I'll just bring up the question of what is the chance of a young, let's say under 25-year-old healthy male who's already been infected with COVID dying from COVID, and which one is higher? And so I think we always have to remember that, that especially at this point with such high population immunity and in young, healthy populations, how much benefit can they actually get? How, Omicron has been milder, we don't know if a more severe variant is going to come, but we have to constantly be like, what are we actually doing? Right. And I think that that's probably why Denmark has said people under 50, unless you're particularly identified as being high risk, we're not recommending that you get vaccinated anymore. No more vaccines. It's just over. They're kind of saying healthcare workers can get it. They're saying specifically children don't get vaccinated unless your doctor recommends it, because of your health condition. So we have to weigh sort of these potential risks with also the potential benefits, which was also one of the big reasons that we did our risk benefit analysis from the VAERS database was, I think a lot of people have sort of not really understood how low risk, especially, healthy young people are. And especially now, this even changed more, and with so much immunity from prior infection.
Right. In term, and it bears mentioning that large Nordic trial, the 23 million, study, again, mostly Pfizer. They don't have much Moderna over there. They actually looked at myocarditis after SARS-CoV, right? SARS-CoV-2, and certainly, the rates of myocarditis seen after SARS-CoV-2, were less,
yes,
right, than what was seen with the vaccine.
28 times less if you combine Pfizer with Moderna. And so it's a really important point to bring up, because first of all, they were only counting hospitalized cases. So we don't even know about the non-hospitalized myocarditis cases after the vaccine. And second of all, they, in the Nordic countries, they had very high testing rates, which we did not have in the US. And so they have a much better sense of what the risk of myocarditis is after COVID than we do. Our studies just cannot, just should not be used if we have their studies, because we are way underestimating. All along, we have been doing that, the number of people that actually had COVID. If we're not looking at seroprevalence, I think it was the Block, was that what his name, in MMWR study that just found actually very high rate of post-vaccination myocarditis in young people, but they still said after COVID it was higher, but it was like they were way undercounting the amount of people that had already been infected. So it was very frustrating conversation.
Right. I mean, there's this massive difference in the U.S. between test positive and how many people actually had it is your point, which is
we've always been all along overestimating the rate of post-COVID myocarditis in young people, and it's due to that issue of, well, and you've brought it, well, both of under testing, but of also, you know, kind of potentially over diagnosing, but it's mostly the under testing issue. We're just testing people who are sick, and people who are asymptomatic, we don't know they had it.
Right.
And that's very common in young people. So.
Right. So, I mean, it's fascinating because when you read the JAMA, it's like a hostage, you know, you read the JAMA cardio discussion from the, you know, on that 23 million cohort where they're showing there's actually less SARS-CoV-2 myocarditis compared to, you know, the two dose regimen, especially with Moderna. The entire discussion, there's like 3 paragraphs, you know.
And
devoted to
like the senior author, Rikard, like he's Swedish, and he told me that they had trouble getting that paragraph added in there. And so I was like, wow, that's fascinating. So it brings it back full circle and tells you, like, you know, sort of how politicized this is. And it's like, you know, it's like there's been this theme the whole pandemic of like sort of hiding certain truths, you know, because it's like virtuous, because then it's like, oh, well, if we do that, we'll increase vaccination uptake and people won't be scared of the vaccine. And it's like, you know, that's just not the way science should be done. Like, I understand there should not be fear mongering, but you shouldn't be like, you know, hiding relevant facts or not publishing those. And, you know, we're talking about myocarditis now, but I just had that same issue with MMWR, not publishing our negative masking study, which is a reanalysis of one that they had already published. So we don't have to get into that, but this has obviously been an issue with scientific journals either not publishing or sort of only wanting to publish certain parts. So that's, I mean, that fuels people's fear about vaccines, right? I mean, because they're like, you know, we're not being told everything. And I mean, I think I look at people, you know, at people like Alex Berenson who are saying like all of the excess deaths might be due to vaccines. And then people, you know, they believe it. They'll be like, oh, well, you know, maybe since they're not telling us anything, you know. And I think that's it's very dangerous to sort of hide certain things because it fuels distrust.
Right. But should we, I mean, is there, do you think it's a mistake to play their game, Tracy? Meaning, what is the reason to play this empirical game that there's no way you're going to win, right? Because I mean, it's clear that I don't know, the left or however you want to say it, that they that they control the narrative, they control the media, they control the tone of coverage, and they will, you know, attempt to personally and professionally, of course, destroy anyone who is going against the consensus. So why even bother trying to play this type? And then you've done it and you've been successful at it, and I kudos to you. But you know, like they're going to take this Florida study, which has the signal, and in the face of like tons and tons and tons of other BS empirical studies that, you know, that they use to close schools for 2 years and mask 2-year-olds and, you know, get $45 trillion of funding for NIH long COVID. Why even play their empirical game? Why not just say, you know, I mean, look, there's a Thai study that was done. It shows this, and you know that even if you were to do a, I don't know, 10,000 RCT study and show something, right, they would pick you apart, you know. And part of the reason they're going to pick you apart.
But not only that. I mean, they would long COVID is their trump card, right?
Yeah.
Because long COVID, I mean, you can't argue with that, right? Because you have to okay, they may admit that there's an increased rate of myocarditis, but they say, but in the totality of things, then you have to think about long COVID. And now long COVID, everybody, right, half the population has long COVID. So unless if you want to continue to play the game, then you should say, look at the rates of, unhappiness after receiving the vaccine.
Right.
Being depressed, right? Right. If you
or just why? I mean, just
fatigued, fatigue after
the
vaccine.
You have that chart with excess mortality and 20 to 40. I mean, I don't know. I don't know if it's worth it. It almost feels like you're like this honest broker, and you're trying to demonstrate something, and you've been doing this all along, and and it's like you're never going to convince. Yeah. This group of Neanderthal science editor, etc. That
I think your point is correct, Anish, because all these studies, I mean, you have to methodologically. There's no other way scientifically. You have to isolate certain, right? You use certain outcomes. It's either rates of myocarditis out of vaccine or this or that. When in fact, what's important is the totality of things, and the people on the other side believe that the whole universe is going to be better off with vaccines. You can't prove that empirically, but it's what they believe. The whole universe, right? The whole cosmic order is better off with vaccines than without vaccines. And anything that goes against that, it's going to be a negative. Whereas we think that the whole universe is better off with people maybe choosing whether they want a vaccine or not. And I don't know that you can, right. I mean, in a way, it doesn't really matter how many.
No, meaning the best you may have. So we're not letting Tracy talk, but.
No, I'm enjoying listening. I'll comment at some point.
the best you may get is, look, you have clustering of myocarditis cases.
Right.
After second dose. Moderna is much worse than Pfizer. And by the way, myocarditis is not mild. I mean, these are the things that you can hit very hard, right? Then when you try to, obviously deaths are going to be very rare. I'm certain there are some, but deaths are going to be so super rare. And any study is going to have major problems trying to get at it. So why not just hit them with what we have, what already exists in terms of the data.
So you're asking me like, why am I sort of like posing these large questions? Like why?
Oh, no. Why do we need to do, like for instance, the bulletin that came on Friday, do we need to do more studies? Because if you try to do more studies, a la, Dr. Ladapo and Florida Department of Epidemiology, et cetera, to try to prove or to try to, do some methodological thing, it's just like a piñata. It's like hanging a piñata out there for, all these cretins to kind of go after.
Yeah, I mean, I do think that's a good question. I mean, because it's like people, I mean, obviously most parents and most young people, most people in general have made up their mind now about whether or not they're getting more vaccines, but we still, I mean, but science is about, investigating what we don't know. I mean, and so it's very, I don't know, it's very concerning that like, only scientists who like find a certain thing or are looking for a certain signal should like, I don't know, are interested in a certain topic should study that. Like, that's just, I mean, obviously this issue of how, I mean, so mRNA platform is going to be used for other technologies, right? And COVID is not going away. And so I probably not, I did not just make a prediction. I don't know, maybe it will, but we suspect it will be around for a long time. There are going to be high risk people for a long time. Like, for the rest of humanity, there will be people who are high risk. And so we want to know, the risks and the benefits. So it's like a fundamental part of science, right? So I think it's great to do more studies. You can't do every study. You have to, I mean, obviously that's a whole different discussion, but like, but I am concerned about sort of the one-sidedness of it, that if you publish a study with a certain result that you're attacked. Like, I mean, that's not helpful to anyone. Like, fine, talk about the results. Like, that's actually what people want. They want critiques of how they did the study, but yeah, like making it a personal thing. I mean, we can talk about AB 2098, the now law in California. I mean, it continues to come up in my mind, obviously. I mean, I almost daily, I have people write threats to me on Twitter about reporting me. And so, I mean, they can't, it's a patient who would report you, right? It has to do with patient care. But I mean, this whole trend of like shutting down ideas and opinions it's very, very anti-science and even, not just even opinions, it's like evidence-based.
But I think you're I mean, everything you're saying is completely right, but you're still talking like somebody that is trying to reason with folks that are irrational. It's like trying to have a rational conversation with somebody from an insane asylum, right? The attack, Tracy, and you know this by now, the attack against Ladapo, the attack against you, the attack against Jay Bhattacharya, the attacks against Vinay, they're not taking place because of what you're saying. They're taking place because of what you represent to them. And what you're representing is you are a threat to their narrative, right? Their narrative is this, and their narrative is this because it's this manufactured scientific consensus, so they can go to the policy people, the politicians, who will then declare an emergency and then try to compel certain actions, whether it be closing schools, whether it be forcing people to take this vaccine or that vaccine or this booster at this interval and stuff. So the reason so many people are so upset with Joseph Ladapo, right, is that he is an MD PhD, he is credentialed, and he is countering the narrative, and he's giving some what's the word,
ammunition,
it's a soft landing spot for those who oppose that end goal, right? And so what they're trying to, so their whole goal is to destroy you, Ladapo, etc., personally and professionally.
But on an optimistic note, haven't they lost the game? I mean, look at the uptake of the new booster.
Right. Yeah, no, but they will keep doing this. They'll keep trying. They'll keep doing this.
Objectively, I guess they've not convinced the public. Like, I feel like,
right,
they've lost the trust of the public. But I even hesitate to use the word they, because I don't want to lump everyone together. Like I have had some people who have really strongly criticized me, who I've actually become friends with afterwards. And I don't mean to seem naive, but I think that that's possible. And it gets back to what I think is probably the biggest theme here, which is how like medicine and science have become very sort of dehumanized during the pandemic and by social media, and how physicians and scientists who have previously maybe worked together, person to person, like right in person, like would not treat each other like this. And so I feel like if the world is going to continue to use social media for their medical and health information, it's actually really important to set a precedent for the future of how science and medical communication is done between professionals. And so I think that there are many very professional people out there who would like to join into the conversation, but haven't felt comfortable doing that. And I think if there's a more sort of welcoming, less threatening environment, that they will feel, more likely to join. But you can tell I'm like an extreme optimist. So, but no,
and I think it's working. I think what you're doing and what others are doing is really worked, and Michelle is absolutely right. I think you're winning, but I think they're gonna redouble. The lunatics and the folks that really need to be quarantined somewhere. They are going to redouble their efforts, because this represents a threat to their power, a threat to their control. But I think you are speaking to the audience per se. You know, when you're talking and to these crazy people on there, you're not so much convincing the person you're talking to, but you're convincing a whole lot of people like who are sitting on the sidelines, kind of watching this kind of interaction take place. So my hope is, I'm very glad you're on, you know, you're on the side of objectivity and you know.
I try. It's hard not to be biased, right? It's also, you know.
Yeah. Well, yeah, it is
like-minded people, and then it's like, you're oh yeah, that makes sense. So, you know, that's why I value a little bit, you know, having those people who attack and maybe not attack, but challenge me, because I'm like, oh yeah, I think about it that way. So, you know, that's
once COVID is well behind us, don't worry. You will come on. We'll bring you on, and we will challenge you about all sorts of things that I'm sure we disagree with. Okay.
We'll find something. Yeah.
You're a Democrat socialist. My goodness.
Do you think so?
You probably have like a Marx textbook you're sitting on or something.
Oh gosh, you know,
I'm kidding.
I would never announce my politics on in public like this. You know, even my family, they can't get me to say anything about it. So
that is really that's very smart. So that's good. I try to be the same way at work. So today somebody, a patient came in who I've seen for a very long time, and she came in with stickers that said, what do the stickers say? Jesus, I cannot. I'm like becoming senile because I want to get the wording right. When she was passing it out in the office, it was hold on. It was a blue thing. I pledged to vote left in November.
Oh boy. Well, she's voting, so that's good. I'm happy, you know.
She's heading down. She's heading down to Florida for the summer, and so I said, "Be careful." Yeah. And so she said she was ready. She was ready for the battle. So anyway, we've taken up a lot of your time, Tracy. I mean, I don't know. Do you write papers while you're running these ultra marathons? These 24 hour. You're one of the nutty people that actually.
I used to run ultra marathons, but yeah. I don't anymore. I still run quite a bit, but yeah. I have a really bad injury.
Oh no.
To my Achilles. So we don't need to get into that, but that's kind of really cut down on the ultra marathon running, unfortunately. So,
oh man,
Michelle. I know, so now I have to do something else. So I write these, you know, do these
for people that don't know, ultra marathoners run continuously for how long? Like 26 hours?
I mean, I'm trying to think. So the longest one I did, it was like 29 hours.
Running
it was so fun. It was on an island in the Baltic Sea, and it was just gorgeous to run all day, all night, like meet people. The most fun. So pretty.
Wow.
Yeah.
Wow, that's incredible. I would be on a golf cart talking to you.
That's awesome.
All right. Well, thanks again, Tracy. It's really, really wonderful, and you know, keep fighting and keep winning. And
yeah, you too. This has been so fun. It's great to talk to you guys.